welcome everybody to the 4th annual Jean Braun Tall Rounds. I'm Brian Griffin. I have had the great pleasure of looking after Jean Braun and getting to know Ellen and with Marty Krapuska, who have been wonderful supporters of Cleveland Clinic. They have allowed us to put on this Tall Rounds and have supported it, supported many things, supported a fellow in imaging, Brian Abity this year, Ben Allencherry last year. And so we have, in honor of Jean, who was an ophthalmologist and a very academic, although private practice ophthalmologist, was very much into research and education. And so this is Brian Abity present the case. I think we're going to have a great case presentation today. It's a patient of mine, actually, that I'd seen that encapsulates, I think, the great teamwork and the great knowledge we have here of valve disease and how we approach things, and the tremendous how complex cases can be managed extremely well here.
Good morning, everybody. I want to start off by once again thanking the Braun family. The year plus I've had an imaging fellowship, I've grown tremendously as a cardiologist, and that's all to the wonderful staff and the program. And so the fact that you can provide that additional fellow for us is phenomenal. So reiterate everything Dr. Griffin said. I'll start off the case, which I think on the surface sounds kind of a simple case, but as hopefully the discussion today will show, there's a lot more nuance and complexity. So we have a 64-year-old woman who's presenting with symptomatic severe aortic stenosis. She's been followed for several years at the clinic with moderate AS, and it's progressed, and she's now presenting with dyspnea on exertion. Brief relevant past medical history. She has history of breast cancer recently with a partial mastectomy, had radiation, currently on tamoxifen. She's heterozygous for factor V Leiden, but had no history of VTE, not on anticoagulation, hypertension, hyperlipidemia. Relevant social history, she continues to work as a school nurse. And physical exam, classic for AS. But I think what's important to note is that she's short in size. She's 5'2", and has a BMI of 34. And she has a preference for TAVR if possible. So I'll briefly go through her echo. We see a peristernal lung axis view, and then the zoomed in version on her aortic valve. You can see it's got restricted leaflet motion. She also has some posterior mitral annular calcification. As we zoom in on the valve, I think it's a little bit challenging to say what the morphology of this valve is, just based on echo. And then when you look at the color Doppler, you see there's quite a bit of flow acceleration consistent with AS, as well as mild to moderate aortic regurgitation. When we look at the hemodynamics, all very consistent with severe aortic stenosis, peak velocities 4.6 meters per second, gradients are 84/51, aortic valve area comes out to be 0.8 centimeters squared. Just briefly look at that mitral valve. We see some flow acceleration through that mitral valve. There's quite a bit of MAC. Gradients are more in the mild end at 9/3. Fortunately, she had a preoperative coronary angiogram, which was normal. And then we get to the CT. So the things I'll highlight, the valve is calcified, moderately calcified. And we look at the planimetry. It's consistent with the echo, severe. The area is around 0.8 centimeters squared. There's a question of whether she has a bicuspid valve and maybe fusion of this non and left coronary cusp. But I think what the crux of this talk will be about is, and I think what makes this case challenging, is her annulus. Her annulus is small. So we see a diameter of 2.3 by 1.8 centimeters, an area of 3.3 centimeters squared. And just to put that in some context, this is the sizing based from the FDA based on the Edward Sapien TAVR valve. And based on that size, that puts her in the 20 millimeter range. Maybe you could try to upsize 23, but certainly she's on the smaller end. So I'll briefly recap the case and mention some relevant points, and then we'll get started with the rest of the conference. So we have a young woman, 64. She has some risk factors, and she's presenting with severe symptomatic AS. The echo is pretty consistent with that diagnosis, although the morphology is a little unclear. We have a 4D CT that supports that diagnosis, but notes that small annulus, and there's a question of, is this valve bicuspid? There's also mitral annular calcification, although with modest gradients. Other relevant factors, she has normal-sized aorta, normal-sized iliac and femoral arteries, no coronary artery disease. So when you plug her into the STS score, she has low operative mortality, less than 1%, but I think there are some subtleties to this case to highlight. Breast cancer with chest radiation. She's genotype positive for factor V Leiden, although at this point phenotype negative, and she has a preference for TAVR. So I think as I approach this case, the things that I'm thinking is, what is the best strategy to replace her valve to avoid prosthesis patient mismatch? Is that even a relevant consideration in 2024? Her valve is thought to be bicuspid, questionably bicuspid. How does that play a role in valve selection? And then lastly, she's young. So how do we best set her up for at least 20, 30, cross your fingers, 40 more years of valve function, set her up for valve and valve? So I think these are the relevant questions as we approach how we're going to replace her valve. So I'll leave you in suspense on what ended up happening, but we'll now hear from the speakers and you kind of form your own opinion.
So Brian mentioned the fact that this patient is a small frame, also small annulus, and one of the fears is that if you put a valve, this valve will be too small for the patient. And this is actually the definition that has many years of what is a patient prosthetic mismatch, and it's essentially a valve that is too small for the patient, and that's what is in many ways related to the size of the patient. And although this definition is based on the size of the orifice, really we detect this patient, we suspect this patient based on an elevated gradient on echocardiography. And in the true cases of mismatch, these gradients occur early on, even after the first echocardiogram, after the intervention, then these gradients are already elevated. Implicit in this definition, but not clearly said, is the fact that the valve has to be normal. So this becoming, in some cases, an exclusion diagnosis because we have to be sure that the valve is otherwise normal. This is easy when the gradients are early after surgery because the valve is, or after an intervention, is fresh and unlikely that is structurally abnormal. But as we often see these patients a little bit after the surgery, and this aspect is less clear. The patient size is important, and lately there have been different criteria for the severity of mismatch based on body size. You can see here some of the definitions if the patient is less than 30 or more than 30 in terms of BMI. And you can see here, at least in the severe, that is a little bit of a difference. And these have been important because it has refocused a little bit, because that was penalizing the more obese patients in terms of mismatch. And there is some degree of correction here that I think was appropriate given this problem. The incidence is as you can see in this slide, varies widely, but I think the important thing is the severe, which seems to be the more clinically relevant, is relatively uncommon, and in the lately series is actually very uncommon. And I think this is something that is very promising for the future of valvular interventions. Again, the incidence varies, and depending on what do you look, this is a very large series of patients with percutaneous or transcatheter valve. You can see, at least at this time, that was a few years ago, the incidence was around 10 to 12% of severe prosthesis mismatch, although the total population with some degree of mismatch is larger. But why are we interested in that? First of all is the question, when you see a patient that the gradients are high, if this is actually a structural failure of the valve, or if just the valve is small for these particular patients. Secondly, in patients with true mismatch, after intervention, maybe the symptoms are not relieved completely. And there has been interest in what is the long-term impact of this mismatch in terms of symptoms and quality of life. There is definitely an increase in reinterventions, either reduced surgeries or another valve in these cases. And again, the question if the mortality in these patients in the long term is also increased in this group of patients. And how is this calculated? And this is where the imaging is very important. Is essentially we do a continuity equation and calculate the valve area. And this valve area is again corrected by surface area. And you can measure the LVOT either by echo, which is the more common way to do that, or you can use a hybrid approach that uses the diameter of the area by CT, and then use the rest of the continuity equation to calculate the area. So this is what we call the measured valve area and the measured patient prosthetic mismatch. There is also a predicted one, which is another method, and there is no measurements. You just go to a table that is either provided by the manufacturer or for historical measurements of normal valves, and then you predict in advance, like in this case that is being shown. If you say that the valve is going to be a 19, you know the area, you divide by body surface area, and you have an idea of what is the patient is going to develop patient prosthetic mismatch. This is important because depending how do you measure either directly or you predict the valve area, the results are quite different. So this is an example of the echocardiographic measurements. This is a parasternal long axis, and the proposed method is to use the LVOT diameter just distal to the frame of the, in this case, a percutaneous valve, and self-expandable and balloon expandable valves. Or you can use a CT scan in this case, and you can planimeter the area. You see these examples, actually there is not even a contrast, and then use this planimeter area for the calculation. In the one labeled by C, you can see the shape is not circular but oval, and therefore a single measurement also introduces another source of discrepancy or error. This has been, again, used, and there are several publications in that regard, where the imaging is used for calculation, but also, again, for the ruling out other morphological characteristics. In this case in particular, for instance, you can see there is a little bit of thrombosis of the valve, and therefore when you have a structural damage or involvement of the valve, then the term shouldn't be used, and instead of mismatch, you should also call directly the pathology, in this case, maybe some thrombosis of the leaflet. But again, very important to use this technique properly, and it's now a standard of care that if you have a prosthetic valve with elevated gradients, that at some point you'll get a CT scan to look at more carefully at the leaflets. Again, these two measurements can produce significant results. This is a patient with the measure by echo show a significant mismatch, but when you use the predicted area by the manufacturer, this patient has no mismatch. These have been all over the literature. Again, depending how do you either you measure or you predict it, you see the wide variability in terms of diagnosis, and how by echo the presence of severe mismatch is usually higher than when you use the predicted values. Again, this is a several cohort, either surgical or by catheter valve. It seems to the problem of this variability with technique is more common with the surgical valve, probably related to the fact that it may be more difficult for us to do the proper measurements of these valves. What are the predictors? And the case that was presented has several of those. Female patients, usually because, again, they are a small frame, and also the valve size that is supposed to be implanted. Based on the annulus, it's thought that it may be a 20, and therefore has two criteria when this patient may develop a mismatch. It's also very important. In terms of what is the prognosis, there have been several papers in that regard. And you can see also depending how the definition is and how big the series and how long these patients are followed, could be from nothing to significant reduce in functional capacity, and in some cases increased mortality. Larger series, I think, are consistent, or most of them are consistent. The mild to moderate mismatch is probably not that important, but those few patients that have severe prosthetic mismatch tends to have worse prognosis overall, either heart failure or rehospitalization, reinterventions, or mortality. And this, again, in multiple series, either surgical or percutaneous, these few cases with severe prosthetic mismatch are important to identify because, again, they may need an intervention or at least follow closely because it has increased complications. In the surgical literature, again, you can see the 6% in this particular series, which is kind of within the range that we expect of severe mismatch. You can see the heart failure in these patients over time increases depending on the severity of the mismatch. In blue, in this case, is severe mismatch. Locally for us, it seems that the incidence or the prevalence of this problem has been decreasing over years, and this is consistent both in the percutaneous and the surgical literature. This may be due to multiple factors. We are much better now to identify a structural failure, and those patients that we used to catalog as mismatch are now properly diagnosed with thrombosis, calcification, or PANUS based on a combination of ultrasound and CT. And also the awareness by the surgeons that this small valve may be problematic, and better techniques in terms of enlarging the annulus, and better design on the valves, which have much better hemodynamic profile. And you can see over time, again, based on this series of factors, either definitions or better techniques, this problem seems to be fading, fortunately for us, because it's a difficult problem to deal with. Again, I want to emphasize that nowadays is a diagnosis of exclusion. You have to exclude other structural morphologies before making this. Just to finalize, this is a complex diagnosis when definitions varies, and you have to be consistent when you look at literature, which definition was used. You need to use a variety of criteria: clinical, echo, I would say CT scan, and in some cases invasive. And the prevalence varies widely depending on the technique or the methodology that you use. It doesn't seem that mild to moderate has major long-term clinical implications, but I think it's important to identify the severe cases because they may have increased mortality and heart failure. And hopefully with more advances and more use of low-profile transcatheter valves, this problem probably will disappear. Thank you.
Thanks, Dr. Griffin, for the kind introduction. Thanks, of course, to the Braun family for the support. So some points to ponder just in the next few minutes. One, what are the outcomes of TAVR and SAVR in patients with a small annulus, generally speaking? Is there a preferred TAVR platform for patients with a small annulus? And also a little bit of perspective from the TAVR side on surgical AVR in patients with a small annulus. So this is a study published recently, relatively small, a low surgical risk group of patients, 151, who were suitable for either surgical or transcatheter AVR. They were randomized 50-50 to one or the other. Ultimately, there's no real difference in valve gradients in the early term, sort of 60-day echocardiographic outcome. And what you also see is that a median follow-up of about 2 years, no significant difference in these clinical outcomes. Again, a small study, a number of caveats. These patients were thought amenable to both treatment options, but perhaps encouraging data to say, ultimately, as a group, when we decide what is the better treatment for a given patient, surgery or TAVR, we're likely to come up with a good solution in either capacity. Now, there's been a lot of interest recently in this idea of self-expandable versus balloon-expandable valves in the small annulus population. This is sort of the take-home graphs from the SMART study that was published recently. This was an industry-funded study by Medtronic comparing their self-expandable supraannular transcatheter valve platform to the balloon-expandable Edwards SAPIEN platform. There were two co-primary endpoints. The second co-primary endpoint that is sort of most talked about is this bioprosthetic valve dysfunction at 12 months that was substantially higher in the balloon expandable platform compared to self-expandable. This is primarily an outcome that was the result of elevated gradients with the balloon expandable valve, mean gradients over 20 millimeters. But what you see is that at 12 months, there's absolutely no difference in clinical outcomes, including things like hospitalization for heart failure. And so one of the considerations is that at 12 months, we're simply not going to see these kind of differences in clinical outcome. But if you actually look back, this was a smaller trial, 240 patients randomized between self-expandable and balloon-expandable valves. At 5 years, there was no difference in clinical outcomes actually between these two groups in major outcomes, except perhaps a higher rate of new pacemaker for the self-expandable platform, which is a known complication. Similarly, there was a non-industry funded study called the Burn TAVI study. In this group, again, out at 5 years, absolutely no difference in mortality for balloon versus self-expandable valves. In fact, the red curves are the self-expandable platform for what that's worth. So there's a number of reasons for this. Partly, Dr. Rodriguez has already discussed these issues of how we truly understand prosthetic valve function. And this is just a very small and somewhat thought-provoking paper that was published looking at 13 patients with a TAVR, with a balloon expandable valve, with a mean gradient over 20. And of those, just over 2/3, in fact, when assessed invasively, did not have a gradient over 20. So there's something here in the echo and how we understand flow dynamics and pressure recovery that perhaps we're not sort of adequately assessing the hemodynamics of the valve. There's actually a larger study called Discordant, which will be presented at the TCT conference next year, looking exactly at this, next week, looking at this difference between echo and invasive gradients. So this is, of course, a controversial topic. We've written a number of editorials on exactly this and trying to be a little bit more critical of the literature and what we know about choosing valves, self-expandable versus balloon expandable. The bottom line really is that there are a number of really patient-specific and anatomic-specific factors that we consider. Specific to this patient down here, we look at the sinuses of Valsalva and the feasibility of a future TAV and TAV, and I'll provide just a case illustration of the same. Again, we do know that there are lower echocardiographic gradients, and if that's the only consideration, maybe aesthetically, that's something to think about. So when we look at our patients, we really need to understand the anatomy of the TAVR prosthetics, the height of the coronary leaflets, the height of the commissure, because when we're going to think about putting a TAVR inside of a TAVR in the future, the index TAVR leaflets are going to go up to the side, and that's where you could or could not occlude the coronary vessels. So this is a patient who has a bit of a bigger annulus than the case presented. This would size for a 23 millimeter valve, not a 20 millimeter like the patient Brian presented. The sinuses are relatively large in size. You can see if you put a self-expandable valve, the commissures would get up to about 26 millimeters. We would not be able to put another TAV inside of that. But with a balloon expandable valve, which is shorter, this clearly leaves the coronaries free for a future TAV and TAV. This was a 74-year-old patient, and so we presume that at 10 years when this valve fails, she hopefully should still be alive, and so that's what we did. And you can see here that there is space there for the left main to fill even after we place another TAV. So the things to consider here with this as a background, for a patient with a 20 millimeter valve, it's a small valve to put another TAVR into. We might not get a full expansion of that second valve, might get even worse hemodynamics than you're worried about at the index procedure. So these are considerations to keep in mind. Certainly if even a balloon expandable valve wouldn't allow sort of freedom from coronary occlusion in the future, that would be a total non-starter for a future TAV and TAV, especially for a young patient like this. So just to close out from a TAVR perspective, what are some surgical considerations? This was a patient with a small annulus who underwent an aortic root enlargement and surgical valve replacement. You can see here the sinuses at the coronary level measure almost 37 millimeters. This was a 25 millimeter surgical valve in which we can place a 26 millimeter TAVR valve. This is simulated, and you can see that even though the coronary is low, with the root enlargement and how the surgical valve was placed, we're going to get coronary flow through here even after we push up the surgical leaflets. So this works out as a great root enlargement and surgical treatment for that patient. This is another patient who had a small annulus, underwent a root enlargement. You can see here the root is certainly larger, and you can appreciate that in the sagittal plane as well. However, just the way the surgical valve is implanted, it really favors toward the left sinus and the left main. And if you look in the sagittal image here, this is the surgical valve frame, and when we put a TAVR in here, that's just going to simply go and occlude the left main. So just doing a root enlargement, putting in a large surgical valve, does not necessarily imply the suitability of a future TAV and TAV. And I think that's something that we have conversations a lot, myself, Eric, Michael, Faisal, about approaching these cases. So to conclude, there's currently no clinical data supporting the superiority of one valve platform over another in patients with small annulus. The right choice for a patient is an important decision that considers root anatomy, feasibility of future options, patient risk, and so forth. Our thorough heart team assessment that we conduct weekly. And in patients with life expectancy that is greater than what we appreciate for the valve longevity, appropriate planning for future TAV and TAV or TAV and SAV must be considered. So thanks very much.
Great. Wonderful. Well, thank you guys for having me today, and thank you to the Dr. Braun family for making this possible for all of us. We're going to build off of the last presentation and incorporate some of the small annulus concepts and take it a step further and talk about how do we approach a patient with bicuspid valve in contemporary practice. I'm going to use a few cases to illustrate important concepts. This is a 68-year-old patient with class 2 heart failure who also has radiation heart disease. So not the same patient, but shares some similarities to the one that we're talking about today. Clearly high surgical risk. And that's one point I want to stress today is that TAVR is currently approved and is an option for patients who are high surgical risk, but we are still collecting data about the right way of managing those patients at lower surgical risk. And this patient is clearly elevated surgical risk for a number of reasons, as you can see from the transthoracic echo and a parasternal long axis view, severe aortic stenosis with suggestion of bicuspid anatomy, which is confirmed on CT scan. A CT scan is really very important for planning because not all bicuspid valves are created equal, right? And some may be, in this case, as you can see, as a Sievers 1, almost a Sievers 0 anatomy with a non-calcified raphe, whereas others may have a lot of heavy raphe calcification, and that increases the risks of paravalvular regurgitation and other issues for TAVR. This patient had a small aortic valve annulus as well, with a cross-sectional area of 3.8 approximately. And as you can see, a very eccentric sinus, but a good transfemoral access otherwise, and otherwise suitable for TAVR, albeit at slightly higher risks. So where does TAVR fit into the armamentarium of treatments for patients with bicuspid valve? And I would rather frame that as to where does it fit in the range of treatments for patients based on their surgical risk and life expectancy. As we all appreciate, the current guidelines now have approved TAVR and give it a recommendation for either a class 1 or a class 2A recommendations in patients regardless of their surgical risk. But it's important, less to think about their surgical risk and more to think about what their life expectancy is. Because if someone's life expectancy is less than 10 years, and if they're high surgical risk, well then, that patient really isn't appropriate for surgery. And those are patients that we may want to push the envelope and think through, well, we're willing to accept a TAVR result, even if it may be a slightly suboptimal outcome. Whereas those patients who are low and medium surgical risk, especially those patients who are younger, we need to be thinking about getting them the best possible result with their initial treatment and also setting them up for success for the future treatment, whether that be surgery or valve-in-valve TAVR, and that is of the utmost importance and very relevant to patients with bicuspid valve. And also very relevant for us today to build on this and say that all the data to date is really from observational studies, right? We don't have any randomized clinical trial of TAVR in bicuspid valves, and that's for a good reason. It's because the anatomy is higher risk, and the suboptimal outcomes, although we have observed great outcomes at our institution, there is increased risk for paravalvular regurgitation, for embolization and rupture. There may be a higher risk of stroke with bicuspid valves, and many of these patients need intervention for other reasons. They have ascending aortopathy or another reason for surgery, and you can appreciate just how eccentric the valves can look inside of the annulus. So, a Sievers 0 valve may be very favorable for a TAVR, and it may be somewhat tricuspid-like in the circularity of the annulus, whereas a Sievers 1, if you have a non-calcified raphe, that may also be fairly favorable for TAVR, but the more calcification you get of the raphe and the more calcification that extends into the LVOT at the annular level, that's where outcomes can sometimes suffer. And these are the things you need to consider, especially as you move into lower risk patients. Fortunately, now we do have some data on lower risk patients, and the PARTNER 3 trial did include a bicuspid registry. And in these carefully selected patients with low risk, out to 1 year, we see that compared to tricuspid valves, patients with bicuspid valves actually did very well, with very low risk of mortality and low risk of paravalvular regurgitation. But again, these patients did not have heavy LVOT or annular calcification, and this is really a propensity score MASH analysis rather than a randomized clinical trial. So, but nonetheless, very high quality, adjudicated, well adjudicated outcomes, and we see satisfactory results. Building on this, which patients with bicuspid valve are at higher risk, right? And this is a very well done study of about 1,000 patients looking at predictors of paravalvular regurgitation with the Sievers 1 bicuspid valve. And as you can see here, there are very clear predictors of paravalvular regurgitation, and they're actually fairly similar to the general TAVR population. And those patients that have severe annular calcification which extends down into the LVOT, valves that are placed too high, this is where you see an increased risk of paravalvular regurgitation. And at least in this series, self-expanding valves had a slightly higher risk of moderate or severe paravalvular regurgitation than balloon expandable valves. So what do we know? And that's that the TAVR is safe, it's feasible, it's very effective, 1-year mortality, maybe very similar to patients with a tricuspid valve, but we also don't know a lot, right? We don't know about long-term durability yet. We don't know about the risk of leaflet thrombosis or halt. We don't know if it affects the evolution of aortopathy. But in patients who are high surgical risk, who really don't have another option, it can be a life-saving treatment, right? And that's what we're talking about today. And whether or not it can serve an important role as a bridge to surgical AVR or ascending aorta replacement in patients who are kind of borderline, like those patients who have radiation heart disease, that's yet to be determined. So here's our case result. As you can see, we chose a 23 millimeter S3 valve, had a wonderful result. This patient did have a CT scan afterwards, to Dr. Griffin's point, and you can just see how the valve does sit somewhat eccentrically in the annulus, but in the sinus, but nonetheless had a great outcome. Just going to highlight 2 other cases, which are maybe pushing the envelope a little bit, also in high-risk patients who did not have a surgical option. And this is a case of a patient who wasn't quite as favorable for TAVR, but we still did TAVR because they had no other option. Severe aortic stenosis, Sievers 1 with the bicuspid valve with a heavily calcified raphe with fusion of the right and the left coronary cusps. Also had a small annulus. But in this case, we chose a self-expanding valve platform. And because of this calcification of the LVOT into the annulus, we were worried that there could be an increased risk of annular rupture. Our plan was to land the valve slightly deeper because of the calcification to see if we can seal better. So we chose a 25 millimeter Navitor valve, and this is actually one of the first bicuspid valves treated with Navitor in the country. So as you can see here, had an excellent result, but needed aggressive pre-dilation and post-dilation, which somewhat defeats the purpose of a self-expanding valve because you're pushing on that calcium in the annulus. So there's trade-offs, right? And although the risk of annular rupture may be a little bit less, as you see from the observational data, the risk of perivalvular regurgitation with the self-expanding valves may be a little more. So you have to strike this balance. And in this case, we were able to get a great result with the 25 millimeter Navitor with gradients, which were absolutely phenomenal given a very small annulus. And then to finish out, this is a case I actually just did 2 weeks ago of a patient who has had a bicuspid valve, also Sievers 1, but very, very minimal calcification on the valve with pure aortic regurgitation. Unfortunately, high surgical risk. So this was TAVR for pure AR in a bicuspid valve, which also has higher risks for all those reasons, but good access and dimensions on the borderline, but favorable for a very oversized self-expanding valve. So we chose to do a 34 millimeter Evolute valve, and just to illustrate some very important concepts and why this should really only be done at centers with expertise in this area, that you have to be very methodical and careful with how you place the valves. And the fear is that the valve can embolize or migrate because of the lack of calcification. So it's almost counterintuitive that you want to start high with your placement because you don't want the valve to slip up. But you need to, because this valve, as you can see, slid down considerably even after deployment. So we're deploying almost at 0 with relation to the annulus. And here you can see that after release, that the valve settles considerably deeper. Right, and this is why you need to be very careful and do this at centers that are comfortable with this. And fortunately, at the Cleveland Clinic, we have more experience with this than really anywhere else in the nation. But this patient had an excellent result for TAVR for pure AR and a bicuspid valve, did not need a pacemaker, and was discharged the next day. So in summary, TAVR is safe and feasible in patients with bicuspid valve with very acceptable outcomes, but the risks are somewhat higher than tricuspid valve disease. And for that reason, it should really only be considered for patients at high surgical risk. And using it as a bridge in those patients who are lower risk, who maybe have yet to develop ascending aortopathy, that can be considered, but we need to really educate patients that just because they have a strong preference for TAVR, it doesn't mean they're never gonna they're gonna go throughout their whole life without a surgery. And we're not quite there yet in terms of the data. So I would caution us against moving in that into that space yet without the data, but I think it's encouraging the data that we have so far. We can do this for pure AR, even with the bicuspid valve in appropriately selected patients, but that's really pushing the envelope and should be done at a center like ours. But the heart team strategy is key, and hopefully this case, these series of cases highlight that it's important to have expertise in all of the TAVR techniques in order to get good outcomes in these patients. Thanks.
So now we're going to get to the exciting part of this tour rounds. Each of our patients presents with their own characteristics. And when I go and see the patient for a surgical consult for AVR, I need to tailor their characteristic to my surgical plan. So I go through a certain checklist in my mind with the patient before I finalize my surgical plan for the AVRs, what the age they are, symptoms, how active they are, comorbidities. Also, their preference for biological versus mechanical valve, and their aortic annulus size indexed to their BSA to avoid patient prosthesis mismatch, how to set them up for valve-in-valve TAVR in the future, what kind of procedure they need. Is it AVR with root enlargement? Are we going to do a root replacement? Or what also other concomitant procedure they need? And what is the surgical approach? Is this going to be an AVR through a mini-invasive approach or not? So as we heard from Dr. Rodriguez about sizing of the annulus, so patient typically present with a surface echo, and we can suspect a small annulus in a surface echo. In that case, we'll need to get a gated CT scan with contrast to get really good assessment, and we need to align, as you see in the bottom, in the 3D reconstruction in the sagittal and coronal planes to get really a true cross-sectional diameter in the axial planes. And if the patient is not a candidate for a scan, another option is obviously get a cardiac MRI. We hear these numbers from Dr. Rodriguez again, but the index effective orifice area is, these are the cutoff, which has been shown in the literature to be the most predictive for worse outcomes, including early high gradient after surgery, recurrent heart failure symptoms, decreased exercise capacities, readmissions, and obviously lower survivals. This is one meta-analysis study run by UPMC group. It's more than 65 studies, more than 120,000 patients. And again, consistent with other studies we've seen before in the prior slides, there is significant difference in survival between people who had patient prosthesis mismatch and no patient prosthesis mismatch after surgical AVR. And also the severe patient prosthesis mismatch has higher risk for readmission for heart failure-related symptoms more than the moderate, and obviously no patient prosthesis mismatch. So we know that patient prosthesis mismatch is bad, but so now how to deal with this. So this is a general scheme I put together based on patient age. So if they're below 50, mostly options are mechanical AVR plus or minus annular enlargement. They can do a Ross or Ozaki procedure. This is going to be discussed by Dr. Onai next. If they're mid-age group, 50 to 70, they're mostly candidate for biological AVR. We have different types of prosthetic valves plus annular enlargement. If they're older than 70, again, some of them are healthy enough, we can still do AVR with annular enlargement. Percival is a good option valve for these patients too. It has a perfect hemodynamics. Still, we can open, clean the annulus from all this calcium, cut the leaflet out, and deploy the Percival valve. And then the last option, obviously, stentless prosthetic like homograft and freestyle, which have excellent dynamics too across. For root enlargement in general, we can divide it into anterior root enlargement, which is a Kono procedure, or posterior techniques, which is called Nix, Manugian, a new technique called Y-patch, and obviously the Commando technique for double valves. So for Kono, I got these pictures from Dr. Roselli. He recently modified the Kono technique to more simplified single patch. We cut through the interventricular septum under the right coronary into the RVUT, and we run a single patch to close the septum and the RVUT, and then we run our aortic valve or Bentel conduit interrupt sutures. And I believe this is a really true enlargement for patient who has problem with small LVUT compared to the posterior enlargements. So this is an example of patient we did together this year. 68-year-old lady had a freestyle for 8 years, coming with very small LVUT under the freestyle. As you can see here in the coronal and sagittal cuts, it's almost 1.5 centimeters. We did a Kono Bental for her, was a Connect 23, and we were able to enlarge the LVUT. You can see massive difference in the LVUT diameter in a cross-sectional. Now it's up to 25 millimeter. So for posterior enlargement, we have the standard techniques, which is Nix, which go through, when we do the aortotomy, we cut through the middle of the non-coronary cusp into the aortic annulus. Manugian, when we cut through the commissure between the non on the left down to the anterior mitral leaflet. And the new modified technique, it's called Y-patch or Y-incision. Again, it goes through the commissure between the non on the left, but it goes transverse under the annulus. And this technique was developed by Bo Yang. He's a surgeon at the University of Michigan. The neck is the simplest one, and we can get one size up. And we cut down in the middle of the non-coronary cusp down to the annulus. We saw a triangular patch, and this actually can be done in even minimally invasive, such as mini sternotomy. Manugian approach, when we cut through the commissure between left and non, down all the way to the anterior mitral leaflet. This is actually the approach for the commando, and we typically do it in the setting of double valve replacement, but you can get more generous enlargement with this and 2 sizes up at least. The Y patch, it's a little bit modified from the Manugian, so we still go in the commissure, but go then underneath the left coronary to the left trigon, and then the right to the right side toward the right trigon, and you get this wide enlargement with a U-shaped kind of patch that goes up to the aorta, and then we use it to close the aorta. And with this, we can get at least 2 sizes up of a tissue valve. So this is a case I just did recently. A 66-year-old lady presented with severe aortic stenosis, was bicuspid aortic valve. Her have elevated gradients and a valve area of 0.7. Her BSA is 2. And when I measured her annular diameter, it was around 21. So if we put a 21 or 23 valve, she will still have mild patient prosthesis mismatch. To avoid, we did a Y patch and put a 25 valve. This is a quick video of this technique. So I'm cutting here from my aortotomy, extending down to the commissure between the left and non, going below the left button toward the left trigon, and then now going to the right side, parallel to the anterior mitral leaflet base. I kind of size my patch and make it a little bigger before I put it in. So this is the Y part that we're going to be running down in the aortomitral curtain. From left trigon toward the right trigon, which give us this big diameter. And then we carry this patch up across the aortic wall. Then we'll do the left side now. And then I size for 25, make sure it looks fine, and I mark with a marking pen when I'm going to go in the patch with the suture. It's a little bit, maybe 5 millimeter above my suture line in the aortomitral curtain. I put my valve suture in the patch from outside in, and the rest is just normal, non-plagiated suture, just to decrease pannus in the future. And as Amar pointed out, we try to put our suture under the left and right coronaries really low to give more room for future valve and valve when we put our surgical AVRs. Sometimes I use the patch to close the rest of the aorta to decrease the tension on the suture line, especially if we oversize by 2 sizes. And here her post-op echo looked normal EF, lower gradient, and scan looks stable. There was no leak. The valve sitting fine in the patch where we can see the root enlargement part in the posteriorly in the aortic root. The last option we have is a commando, but this only applies for people who are coming for double valve replacement with this. So if they have small aortic annulus, something we consider, especially for reoperation. Patient had, for say, small prosthetic valve sizes in the first operation. We get referral from these cases a lot here. So that's one tool we can use. Radiation heart disease, rheumatic or small valves, or severe calcification, such as patient with dialysis or MAC. So the idea that we do the Manugian exposure, go down through the commissure and anterior mitral leaflet, cut the mitral valve out, put the mitral valve first, and we use a double-sided patch to close the roof of the left atrium and then close the aorta. And that at least gives us also 2 sizes up in the aortic valve. So in conclusion, these patients, we have to really be careful when we assess these aortic annulus. So if the patient comes with a surface echo, we have to get a scan gated to scan with contrast to get really good sense of the aortic annulus diameter. When we put our surgical plan, obviously we need to avoid patient prosthesis mismatch. And it's very simple. We have an app on the phone that you can put the patient PSA and look at the available valve sizes. And the app actually tell you if you'll have a mild or severe patient prosthesis mismatch. So it's something easy to avoid. We also need to set up for long-term plan for our patient for valve and valve TAVR in the future. And some of the aortic root enlargement are not complex. They can be actually done in a mini sternotomy incision. And again, heart team is very important to look together through these patients and tailor the best plan for them. Thanks.
So I'll talk about a little bit about Ozaki procedure and a little bit of Ross as well. So I think patient prosthetic mismatch is bad, but what we don't really appreciate is that normal aortic valve area is 4 to 4.5 centimeters square, whereas even the biggest bioprosthetic valve, the area is only 2.5 or so. And why is that? So the native aortic annulus expands in systole and increases the area about 10 to 15%. So when you put in a rigid stented valve, the annulus can't do that, which decreases the EOA. You can see this this is an ex vivo experiment, but native valve and Ozaki valve, even if you start out with a small EOA, if you increase the flow, the EOA increases quite a bit, much more compared to any kind of tissue valve or mechanical valve. When you look at 4D CT, the flow is very laminar with Ozaki and Ross as well. And not just the hemodynamics, but these are all the limitations of prosthetic valves: thrombosis, bleeding, and infection. And that leads to decreased life expectancy. And a 25-year-old will have about 50 plus years of life expectancy. However, if you get a mechanical valve or a bioprosthetic valve, that you lose about 20 years of your life if you get a mechanical valve or a bioprosthetic valve. If you look at 55-year-olds, even at a 55-year-old, you lose about 7 to 10 years with a mechanical valve or a bioprosthetic valve. And we know, we've seen a lot of data from Ross enthusiasts that Ross procedure can restore normal life expectancy, but how about Ozaki? So in order to answer that, I sent a fellow to work with Ozaki for a few months and collected all the data. And we collected echo and all the other demographics and stuff for about 1,200 patients, and we analyzed the data here. So at 10 years, the mean grade, granted that this patient population is a little bit older patients, about average age of 68. So at 10 years, the mean gradient stays stable about at 8. And at 10 years, 93% of patients had mild or less regurgitation. And freedom from reoperation was over 90% at 10 years. Half of them were in the carotids and half of them were degeneration. And when we look at Ozaki, it's a very good valve, but when we do it in smaller annulus, how does it perform? The grading increases a bit after when it's smaller than 21, but it only goes up to about 9, and still the gradient is in the single digits. The other factors associated with higher gradient was the material. Ozaki has been using some bovine pericardium, which does have a little higher gradient. We typically just use autologous pericardium. And higher creatinine and dialysis patients had a higher gradient. Similar trends were reported from a European group that looked at patients with an annulus of less than 21 that was reported to have a EOA of 2.5, index EOA of 1.3. The gradient was low as well. And same results from a Japanese group as well. And all these good hemodynamics lead to better reverse remodeling, which continues up to 10 years, which is very different from what you see for any kind of prosthetic valve, which the reverse remodeling only continues up to 2 to 3 years, and then the LV mass starts to increase again afterwards. And the survival is very similar to age 6 matched general population in Japan. So this is a couple clips from recent surgery, and you can see that it's clear that the valve opens wide, and I traced one of these echoes, and the area was about 4. And this is a clip that Dr. Ozaki shared with me after 15 years after Ozaki, and again, the valve is opening and closing well, and there's no AI. So I think Ozaki and Ross are just one of the options that we can offer to our patients, and I think it's important to tailor it to our patient. And we have all the other options, and it's important to discuss with the referring cardiologist and an interventional cardiologist and us and the patient to choose what is the best for each individual patient. Thank you.
In the interest of time, have Brian go through what actually happened with this patient, and then maybe we'll have time for a few questions.
So I'll keep it brief. She got an Ozaki procedure, and pathology did confirm a bicuspid valve.
Fantastic. So she did have an Ozaki procedure, which meant that Dr. Unai did the surgery, pretty much. I mean, he's done a lot of the. So can you just take us through why you approached? I know we had a lot of back and forth with this lady as to what would be the best approach. What made you convince her and yourself that an Ozaki procedure? Now, for people who may not know, an Ozaki procedure is where you take the patient's own pericardium and you fashion it into a valve. It's you need to be a good. Well, surgeons are good carpenters. You kind of need to be a good tailor or seamstress to do this. So, what were your thoughts in doing this?
So I know that she really wanted a TAVR, and so it took a little bit of time to convince her. So we talked about all the options: minimally invasive and root enlargement, and Ozaki. I didn't talk about Ross because she's a little bit older than that. So, and what I do when I see these patients is that I show them all the literature that we have and have her decide what she wants. And she came back to me and she said that she wants Ozaki. I like this idea. And of course, the better EOA for her size could offer her better long-term, hopefully better long-term survival, which we'll know in a few years how Ozaki performs long-term.
And what do you think the possibility of doing a valve in doing a TAVR in an Ozaki in the future? Is there any data on that?
So we don't have any data on that, and I think what we don't know, and Shinya and I have talked about this, the Ozaki tends to have deeper sinuses and longer leaflets, and so how that's going to sort of relate to the coronary ostia, I think, will be a relevant consideration. The other thing, for example, the Ross tends to degenerate with AR, and right now we don't have a great option for transcatheter treatment of AR, and so it'll be interesting to see how the Ozaki degenerates, whether it's more on the AR side of things or the AS side of things, which is more relevant to TAVR.
Shinya, were you concerned with the history of radiation and the use of the autologous pericardium?
So I believe that her radiation was not for Hodgkin's, it was for breast cancer, so I think the radiation is fairly limited. So in those patients, I really don't see a lot of changes in the mediastinum, so I wasn't too concerned. And obviously, but if I look at it directly, if the pericardium thickened, I wouldn't use it. And the comment about the Ozaki, TAVR and Ozaki, is that the leaflet is very tall now, and so that's part of the reason why it's not really suitable for a TAVR, but the newer templates are coming out soon, and which has a little lower coaptation, and hopefully that would be a better platform for a TAVR in the future, if needed. But hopefully we don't have to do a TAVR.
Hey, thanks again. This was fantastic. Congratulations to the panel for this great presentation. This is why, a patient like this should come to a place like this, because statistical likelihood is if this person were somewhere else would have probably gotten a TAVR, a small 20-millimeter TAVR, which then, in 7 to 10 years, they would need something else, valve in valve, et cetera, versus a TAVR explant. So can people comment on where we stand with the current data in terms of TAVR explant? There's emerging scary data from literature, but where do we stand?
So always a provocateur, Dr. Desai. So what I will say is that the data that exists on TAVR explant is horribly messy data. It is data on people who had TAVI when they were already high risk at the index time.
Many of the cases were for endocarditis, which are complex surgeries in the first place. And then secondly, in numerous centers and not necessarily with always great level of surgical expertise. So the data at its baseline, or at face value, says that TAVR explant is risky and has high 30-day mortality. Many of the surgeons in the community, including ours, will say that that data does not reflect sort of appropriate practice. And so I think that, for example, many of the patients we share with radiation background, specifically Hodgkin's lymphoma background, we generally will treat them with TAVI in their 50s or 60s because their mitral valve disease isn't yet significant. And then 5, 8, 10 years later, when their mitral valve has progressed, they then go and have a surgery. And we have a reasonably modest size group of these patients. And, Shinya, Eric, they've all taken out these TAVIs. And with good technique, it doesn't really add that much. So I would say the jury is out on is TAVI explant in the appropriate surgical center and appropriate clinical scenario really riskier.
Eric, please.
Well, I appreciated all that teasing up front about TAVR, but 64-year-old, no-brainer. This lady had to have surgery. So I'm glad that at the end, the punchline was that the patient had an operation. She got the right thing done. I think. I'm a little surprised, Shinya. I'm going to put you to task here. In a 64-year-old who maybe she's going to live to 80 and this valve's going to degenerate, why you chose an Ozaki when the slides you showed was that's a choice for younger patients, not a 64-year-old. I know 65 was the cutoff. And the leaflets are tall. I'm a little worried that, TAVR is going to be a tricky option, but I suppose maybe you're just challenging our outstanding structural partners here. Like you guys are going to have to do one of your fancy techniques to split these leaflets or something. Can you comment on that kind of extra technique? I didn't hear a whole lot about that in the bicuspid, maybe. Grant for us, number one, and then I have another comment.
These are wonderful points to Dr. Roselli's points. With any of the self-expanding valves that have higher leaflets or the Ozaki, which will have higher leaflets, you do worry about the risk of coronary obstruction in the future. And the leaflet modification techniques are feasible in many patients, but they're also quite cumbersome. And it's really better done at centers like ours that have an expertise and a concentration in this, because there are complications associated with it. There are technologies which are coming. They're very expensive. The application of that to an Ozaki valve, I don't think there's ever been a case, to my knowledge. But that said, these are future challenges that we're going to have to face. We are constantly trying to innovate and get better with it. But leaflet modification is feasible in many patients. It assumes commissural alignment of the initial valve that's placed in Ozaki. That won't really be an issue. Snorkel stenting is the other option. And it is somewhat unappealing to be, snorkeling a long stent into the sinus in many patients, especially younger patients, because that eliminates any future valve and valve options after that, and we don't know the long-term outcomes. So this is why it's so important to plan ahead with that initial procedure, right? You got to be thinking down the line, like what's next? And this is why I tell patients that argument often wins them over for surgery, right? And a young patient like this, I'm very glad they had surgery as well, and they were agreeable to it because their preferences, although it's TAVR often, when they see the data and you talk it through, they'll change their mind. And patient preference alone shouldn't be what we use to make our decisions. We have to tell them the honest truth about things, and it's all about strategy, right?
Yeah, durability is key. I mean, some slides all showed 10 and 15-year outcomes, and you guys showed much shorter-term ones. So, I mean, that's a really important part of the conversation. And Shinya, hopefully with this awesome hemodynamic performance, we never have to worry about this valve degenerating.
Yeah, so just one comment, since you put me on the spot. So when I go talk to Ozaki and when I see him operate, he does Ozakis for anywhere from teens to his oldest was 89 or something. So which is, a little crazy. But that being said, I think there is benefit for any age population. Like it showed, the reverse remodeling data is very interesting that that doesn't happen with any kind of prosthetic valve. So it does show that the valve hemodynamics are good, and that is something that lasts. And hopefully we don't even have to think about doing a TAVR in the future. But like 10 years ago, there was no TAVR. And, you know, who knows in 10 years what will be possible to do with catheter. And the other issue is that, you know, valve-in-valve TAVR is great. You know, no disrespect, but the results of valve-in-valve TAVR is not really established yet. We don't have really long-term results yet. So I don't think, you know, doing a procedure aiming for valve-in-valve TAVR is the best thing.
Fair enough.
That's a whole other concept.
Yeah. If I could just make one other comment, because you did present a case with AI. I think that's totally off subject here. A lot of those valves need to be repaired, and that's an option we didn't talk about at all today. I just want to float that out there. Maybe like a little coming soon for another tall rounds, Katie. We'll have a tall rounds about valve repair. Thank you.
Thanks very much, Eric. Well, I think this was a wonderful expose of really, you know, technically and clinically very interesting points that are important and that really do highlight the expertise that we have here. I want to thank all of the speakers for their fantastic presentations. Of course, I want to thank Ellen and Marty for being here. Thank Brian for putting this together. Brian Abity, I think you actually passed. I think you're coming on staff. You know, you did this. You've certainly made it here. You did a great job. And thanks everybody.